It's increasingly common to encounter individuals presenting with chest pain that strongly mimics angina. Yet, when we perform an angiogram, a CT coronary angiogram or an invasive one, the major coronary arteries that we call the epicardial coronaries appear normal. They don't show any significant blockage. In the past, we often referred to this as Syndrome X, a kind of placeholder name because our understanding was limited. Consequently, when patients described their chest discomfort, it was sometimes easy to dismiss their symptoms as anxiety, panic attacks, or gastrointestinal issues. Sadly, their concerns were not always taken as seriously as they should have been. And that's because our traditional understanding of the heart's blood supply has primarily focused on the epicardial coronary arteries. These are the larger vessels that encircle the heart, much like a crown encircles a head. Hence the name coronary, from the Latin corona, means the crown. Also, since the 1940s, we had the angiography that allowed us to visualize the intricate details of these epicardial vessels. Moreover, techniques like intravascular ultrasound and physiologic assessments have further enhanced our understanding of the epicardial coronaries. For decades, our interventions have centered on treating blockage in the larger vessels through balloon angioplasty, stenting, and bypass surgery. However, we often overlooked a crucial fact. These epicardial vessels only account for a portion of the heart's total arterial supply. Our ability to study and truly understand the microcirculation that makes up to 10% of the heart's mass has only improved relatively recently. Now, our recent understanding of coronary artery disease is that epicardial coronary stenosis is just the tip of the iceberg. It is more common in males, whereas ANOCA represents 50 to 70% of angina in females. Patients who experience angina with no significant blockage in their epicardial vessels present a significant challenge. Accurate diagnosis is often delayed, leading to the lack of appropriate therapy. The symptoms can be quite variable, and the clinical presentation may fluctuate over time. They can present with what we consider classic angina symptoms, but they also can present with breathlessness, indigestion, nausea, fatigue, weakness, or even sleep disturbances. When misdiagnosed, these individuals do not receive the right management, resulting in persistent or recurrent angina, reduced quality of life, frequent hospitalizations, and unnecessary repeated coronary angiograms. So in this episode of CardioBuzz, we'll be discussing angina with no obstructive coronary arteries, ANOCA, and also ischemia with non-obstructive coronary arteries, INOCA, and we'll explain the difference between both terms. We'll explore their impact on health and the associated adverse events. We will cover 4 key aspects: the underlying pathophysiology of ANOCA, how we diagnose it with a special focus on invasive assessment, and finally the treatment strategies. But please note that this video is larger than our typical videos. Therefore, settle in and prepare to focus as the journey ahead demands your complete concentration. Welcome to CardioBuzz.
Welcome back to CardioBuzz, your concise and reliable source for cardiology education, reviews, updates, and challenging cases. Subscribe now to stay ahead with the latest advancements, refine your understanding, and engage with content designed to support your practice and enhance patient care. Let's learn together.
To understand the pathophysiology, we need to delve first into the structure of the coronary blood vessels. We can think of the coronary arteries as a tree that has 3 or 4 orders or levels of branches, each with a distinct role and feature, not even considering the veins. First, we have the epicardial vessels. These are the large coronary arteries, the ones that we see on the standard angiogram. Their diameter ranges from 0.5 millimeters up to 4 or 5 millimeters. The primary function of these vessels is conduction. They conduct pressure and blood flow. They dilate and constrict in response to changes in blood flow. This is called flow-mediated dilatation. They offer very low resistance to the overall coronary circulation. As we move further down the arterial tree, we reach the prearterioles, which range in diameter from 100 microns up to 0.5 millimeters. These are often difficult to see clearly on a standard invasive angiogram. As the blood flows into these prearterioles, we start to see a rise in resistance. And the next level is the arterioles, which are even smaller, less than 200 microns in diameter. These arterioles and prearterioles are highly responsive to changes in the pressure. When the coronary pressure drops, they tend to dilate. When the pressure increases, they constrict. They are responsible for the pressure-mediated regulation. And these arterioles offer the greatest proportion of resistance within the coronary circulation. Finally, we have the capillaries, which are the smallest vessels with diameters less than 10 microns. The primary regulation is metabolic. They dilate or constrict based on the local metabolic needs of the heart muscle. Under normal conditions, they do not offer any significant resistance to blood flow. And now let's consider the different pathologies that affect the coronary vessels at each level. In the epicardial coronary arteries, the conductance vessels, the least resistance vessels, the most common pathology is atherosclerotic disease, the buildup of plaque. Other possible pathologies include myocardial bridging, where a segment of the coronary artery runs within the heart muscle, coronary ectasia or aneurysm, and epicardial spasm, which can occur alone or with underlying atherosclerotic disease. The prearterioles can be affected also by atherosclerotic disease, a small vessel disease, and can also be affected by an impaired ability to dilate in response to pressure drops, which can lead to ischemia, of course. For the arterioles and the capillaries, the resistance and the metabolic regulation, we have several pathologies, including microvascular spasm, which is spasm of the small vessels, rarefaction, which is a decrease in the number of small vessels, inward remodeling, narrowing of the vessel wall, and microvascular plugging. These processes are similar to what we see in the cerebral vessels with long-standing diabetes and hypertension, leading to hyaline degeneration of the arterioles, resulting in cerebral lacunar infarcts. Additionally, the capillaries can be compressed by myocardial hypertrophy or myocardial edema, in cardiomyopathy or myocarditis, respectively. All of these issues can impair the blood supply to the heart muscle, resulting in angina or ischemia. So, differentiating between ANOCA and INOCA, INOCA is a subset of ANOCA. Only 25% of patients with angina and no occlusive disease will have demonstrable ischemia by non-invasive testing, and we call those 25% INOCA. And so we have three main pathologies in ANOCA. The most common pathology is endothelial dysfunction. It's seen in around 80% of ANOCA patients. The second most common is vasospastic disease, either of the epicardial vessels or of the microcirculation. This affects 60% of ANOCA patients. The third and the least common, still seen in 50% of ANOCA patients, is abnormal coronary microvascular function, impaired vasodilatation, or high microvascular resistance. It's important to remember that patients can have a combination of these underlying issues, and there will be some individuals whose specific pathophysiology does not fit into any of these categories. Let's start by endothelial dysfunction. Endothelial dysfunction is characterized by impaired functioning of the endothelium, which is the thin layer of cells lining the blood vessels. All evils stem from endothelial dysfunction. It has dozens of causes: aging, hypertension, diabetes, obesity, smoking, pollution, sedentary life, junk food, refined sugars, dyslipidemia, chronic inflammation. All of these factors increase the production of reactive oxygen species that will damage the mitochondria, reduce the availability of the heavenly molecule nitric oxide. Nitric oxide is a natural vasodilator, antithrombotic, and anti-inflammatory. Depletion of nitric oxide promotes inflammation, thrombosis, and vasospasm. Endothelial dysfunction is the earliest marker of cardiovascular disease. It can manifest as angina, cognitive decline, or even erectile dysfunction. The diagnosis of endothelial dysfunction can be established clinically by Doppler ultrasound, where we try to measure the flow-mediated dilatation in the extremities, or by analyzing the levels of nitric oxide, von Willebrand factor, or tissue plasminogen activator. The second most common pathology is vasospastic angina, which is excessive constriction of the epicardial coronary arteries, resulting in dynamic obstruction to blood flow. It can coexist with microvascular angina, leading to worse prognosis. Vasospastic angina results from endothelial dysfunction and abnormal function of the smooth muscle cells in the arterial wall. We diagnose it by provoking spasm during invasive testing. It's more common in patients of Asian origin. It's influenced by hormones, is more frequent in postmenopausal women. Vasospasm can be induced by smoking, cold exposure, hyperventilation, or even allergic reactions. Vasospasm is associated with increased risk of serious events like death, MI. And the third most common pathology is microvascular angina. There are structural or functional changes in the coronary microvasculature, leading either to impaired vasodilatation or structural remodeling or compression by myocardial hypertrophy. We diagnose microvascular angina by demonstrating reduction of coronary flow during stress. The risk factors for microvascular angina are similar to those of endothelial dysfunction: smoking, aging, diabetes, hypertension, dyslipidemia, and inflammatory conditions, as well as psychosocial stresses. We previously thought that microvascular angina is a benign condition, but now we know that microvascular angina is associated with a 2 to 4-fold increased risk of adverse cardiovascular events. Moving on to how to diagnose these conditions and differentiate between them, we will elaborate more on this when we discuss invasive testing. But in a nutshell, we diagnose endothelial dysfunction in the coronary vessels based on the response of the coronary arteries to a low dose of acetylcholine injected intracoronary. Vasospastic angina is diagnosed by observing significant constriction with a high dose of acetylcholine also injected intracoronary. We diagnose coronary microvascular disease by directly or indirectly measuring the coronary flow and assessing its response to stress. Moving on to the diagnosis of ANOCA. The diagnostic pathway usually begins when a patient presents with chest pain or other suggestive symptoms. Of course, history taking, physical examination, and ECG and echocardiography is particularly essential here because it can diagnose conditions that cause angina: mitral stenosis, mitral valve prolapse, aortic valve disease, cardiomyopathies, pulmonary hypertension, pericardial diseases. If any of these conditions is diagnosed, then the cause of angina is clear and can be treated. If the initial tests do not reveal a real cause of chest pain, then we usually proceed with functional testing, exercise ECG, nuclear stress test, stress echo, cardiac MRI. We discussed which test to choose in different patient scenarios in a previous episode, and you can find a link to that in the channel. Eventually, to assess the coronary arteries and determine if there is occlusion or not, we perform a coronary angiogram, either invasive or CT scan. If these are normal, then this is angina with no obstructive coronary arteries. So there are 4 key criteria or pillars to diagnose ANOCA. Number 1, symptoms. The patient must have some chest pain or other symptoms that are suggestive of angina. Then we may need to show objective evidence of myocardial ischemia. This can be present in non-invasive testing. This is the case in only 25% of patients with ANOCA, so it is not essential for the diagnosis. Of course, we need to have absence of obstructive coronary disease in an angiogram. And finally, we need to have evidence of impaired microvascular function or coronary vasospasm during the invasive testing. It's important to reiterate that having objective evidence of myocardial ischemia may not always be present. In many instances, we will make a diagnosis based on 3 out of 4 criteria. Then moving on to the invasive testing. In the last decade, we've gained access to sophisticated tools that help us further investigate both the epicardial coronary arteries and the microcirculation. We'll now elaborate on how these invasive tests allow us to assess epicardial stenosis, examine microvascular function, and provoke spasm. It starts by a standard epicardial coronary angiogram, where we can find pathologies other than atherosclerosis, myocardial bridging, aneurysms, or coronary ectasia, and the treatment of these conditions will be discussed later on. One of the interesting phenomena that we sometimes observe is slow flow, which is not uncommon, particularly seen in young male smokers presenting with angina and acute coronary syndrome. These individuals often have elevated resistance in the microcirculation and more severe myocardial ischemia, and they have high risk of adverse events. However, it's important to note that there is not always a direct correlation between slow flow and elevated microvascular resistance. That's where more sophisticated invasive tests become useful in many patients. But first, a significant proportion of patients, especially above the age of 60, may have some visible stenosis in the epicardial arteries. However, the visual assessment alone is not always accurate. Therefore, we need a more objective assessment to confirm whether the stenosis is truly significant or not. So this leads us to the 3-step approach during invasive coronary assessment. Number 1, we assess the epicardial vessels for stenosis during the angiogram. Number 2, we try to induce vasospasm. Number 3, we assess the coronary flow directly or indirectly at rest and at hyperemia by induction of vasodilatation to diagnose microvascular disease. It's crucial to understand that these invasive tests are not always straightforward and may not be readily available at all centers. They require specific patient preparation. Typically, the procedure is better performed via the femoral approach, because if we use the radial approach, we may need to give nitrates or verapamil, which can interfere with the test results. Besides, we usually avoid sedation during the procedure because we need to provoke chest pain to correlate with any observed changes. A 12-lead ECG is essential, not just the standard monitoring lead, as we need to look for ST changes in different territories. Finally, patients need to stop vasodilator medications well in advance of the procedure. For example, amlodipine may need to be stopped several days before the test, verapamil for 2 days before the test, and nitrates for probably 12 hours before the test. And as we said, the invasive assessment is done in 3 phases: the standard angiogram, induction of vasospasm, and then assessment of coronary flow. And the most common agent used to induce vasospasm is acetylcholine. And let's first look at acetylcholine because this is a fascinating molecule. While we use it to induce vasospasm, we must be aware of the contraindications of injecting acetylcholine, such as severe bronchial asthma, can cause bronchospasm, chronic kidney disease, as the procedure may require additional contrast, and we may need to have a pacemaker ready. Acetylcholine is intriguing because the response of the coronary vessels to acetylcholine depends on the health of the endothelium and the dose administered. The low dose of intracoronary acetylcholine, 2 to 20 micrograms, usually causes the coronary arterioles to dilate. This is mediated by the release of nitric oxide from a healthy endothelium, a pathway that we call nitric oxide-dependent pathway. In contrast, higher doses of acetylcholine can constrict the larger epicardial coronary arteries, especially if there is endothelial dysfunction. Therefore, the response to low-dose acetylcholine gives us valuable information about the function of the endothelium. A normal endothelium will respond with vasodilatation, while a dysfunctional endothelium lacking sufficient nitric oxide may not dilate properly or even cause epicardial vasoconstriction. So small dose is an arteriolar vasodilator, where large dose is an epicardial vasoconstrictor, especially with endothelial dysfunction. Acetylcholine is injected into the left coronary or to the right coronary. We start with incremental doses of acetylcholine, 20 up to a maximum of 100 micrograms, waiting for 2 minutes of washout between each dose. After each dose, we assess the patient's ECG, symptoms, and repeat the coronary angiogram. And there are 3 possible outcomes of the acetylcholine test. A normal test where there's no chest pain, ECG changes, and no angiographic evidence of spasm. An abnormal test where there's either epicardial spasm or microvascular spasm, or an equivocal test where there are incomplete findings such as angina without accompanying ECG changes. An abnormal test, which is a coronary spasm, could be either epicardial or microvascular, and the epicardial could be focal or diffuse. Epicardial spasm, we see it on angiography by 90% diameter reduction. We see ischemic changes on the 12-lead ECG, and we reproduce the angina of the patient. If the 3 criteria are fulfilled, this is epicardial spasm. Whereas if we only see ischemic ECG changes and reproduction of angina without an epicardial narrowing, then this is microvascular spasm. And after we assess for coronary vasospasm, we assess for coronary vasodilatation or hyperemia. And we do this by injecting a strong vasodilator. The most commonly used is adenosine. By doing so, we assess different parameters of coronary blood flow. We look at the FFR, we look at the CFR, and we look at the IMR. And don't be intimidated by these abbreviations, we'll explain them shortly. But first, how do we actually measure the coronary flow? It's not directly visible on the angiogram. So instead, we need to rely on fundamental physical principles, specifically the Ohm's law, which states that flow is equal to the pressure divided by the resistance. If we have 2 of the 3 variables, then we can easily calculate the 3rd variable. Let's start first by how do we assess epicardial lesions using the FFR. FFR is the ratio of maximum blood flow distal to the stenosis compared to a maximum blood flow if the artery was normal. To measure this, we use a specialized wire that can cross the lesion and measure the blood pressure before and distal to the narrowing. So we have the pressure component of the Ohm's law. And in order to effectively assess the impact of stenosis on flow, we need to minimize the resistance in the downstream vessels by inducing maximal hyperemia. When we do that, we assume that the resistance is nullified, especially that the pressure in the coronary veins is close to 0. So in the conditions of maximal flow, the flow is proportional to the pressure drop. And the ratio of the distal pressure to the proximal pressure of 0.8 is the cutoff that this stenosis is severe and needs to be treated invasively. Then let's consider the CFR, the coronary flow reserve. The CFR is a measure of how much of the blood flow in the coronary arteries can increase above its resting level in response to stress or demand. It's a ratio of the maximum coronary flow during hyperemia to the resting coronary flow. A normal CFR is considered to be greater than 2 to 2.5. So the crucial question is, how can we measure the coronary blood flow? We do this indirectly using the principle of thermodilution. This technique is based on the idea that if you inject a known amount of fluid at a known temperature into the bloodstream, the change of the temperature downstream can tell you about the volume of the blood flow. Think of adding a drop of cold water to a flowing river. The faster the river flows, the quicker the temperature will dissipate. In the context of coronary flow, we use a specialized wire with a temperature sensor at the tip. We inject a small bolus of room temperature saline into the coronary artery, and we measure the temperature downstream as measured by the sensor. A faster drop in temperature indicates a higher blood flow. There's the basic thermodilution equation called Stewart-Hamilton equation. We don't need to calculate it, of course, the machines can do that, but the general principle is that the more the flow, the quicker the temperature will dissipate. And we use the same principle in measuring the cardiac output in right heart catheterization. A patient with poor cardiac output will have prolonged circulation time compared to a patient with normal cardiac output. Instead of measuring the area under the curve, we have a surrogate, which is the mean transit time. The shorter the mean transit time, the larger is the flow. A faster drop in temperature indicates higher blood flow. So instead of the full thermodilution equation, the key parameter that we look at is the mean transit time, the average time it takes for the temperature change to pass through the sensor. A shorter mean transit time means faster flow. So to calculate coronary flow reserves using thermodilution, we measure the mean transit time at rest, and then again at maximal hyperemia induced by adenosine. We can measure at the same time the FFR and the CFR. The CFR would be the ratio of the mean transit time at baseline and at peak hyperemia. We have another technique less commonly used, which is the intracoronary Doppler. The Doppler wire can measure the velocity of blood flow at baseline, and after inducing hyperemia, the CFR is the ratio of the Doppler velocity at hyperemia compared to the baseline. We also have non-invasive techniques like myocardial perfusion scans and cardiac MRI. They can also give us an idea about the myocardial blood volume at rest and stress, giving us an indirect assessment of coronary flow reserve. However, the invasive assessments with the thermodilution wires are considered the gold standard for assessing the CFR. It's important to remember that CFR is an integrated marker. It reflects the health of both the large epicardial arteries and the small microvessels. A reduced CFR can be due to a significant epicardial stenosis, microvascular dysfunction, or combination of both. It has also been shown to correlate with adverse cardiovascular outcomes. So to summarize, we measure flow across the coronary circulation by using the thermodilution techniques, and we utilize the Ohm's law, where the flow equals the pressure divided by the resistance. The CFR gives us the entire coronary circulation, both epicardial and microvascular, where the FFR gives us only the epicardial coronary arteries. And we can also derive a specific index for the microcirculation, which is the index of microvascular resistance. So how can we measure that? Again, we depend on the Ohm's law. To assess resistance across the microcirculation, then the pressure here would be the distal coronary pressure minus the coronary venous pressure, which we assume close to be 0, divided by the flow. As we discussed, instead of the flow, we use the mean transit time as an inverse surrogate of flow. Therefore, the IMR would be simply calculated where the resistance here equals the distal pressure, because the venous pressure is cancelled, not divided by the flow but multiplied by the reverse of flow, which is the mean transit time. And an IMR of more than 25 means microvascular dysfunction. So this diagram illustrates how we measure FFR and CFR and IMR using thermodilution. We inject a bolus of saline at rest, and again during hyperemia. The changes in the temperature over time gives us the thermodilution curves. A shorter curve means larger flow or faster flow. Bolus injections help us to calculate CFR and IMR, They do not give us the absolute volume of blood flow. For that, we need to depend on a continuous infusion technique that's usually used in research settings. So how do we interpret these invasive findings? After performing the coronary angiogram, inducing spasm with acetylcholine, and then inducing vasodilatation to measure the coronary flow at rest and peak hyperemia, we can arrive at several possible diagnoses. For microvascular disease, there will be no significant epicardial stenosis. The FFR will be more than 0.8, but we will have reduced coronary flow reserve and often an elevated index of microvascular resistance. Vasospasm testing may be negative or show evidence of microvascular spasm. For vasospastic angina, acetylcholine provocation will induce the significant spasm, often associated with angina and ischemic ECG changes. When we induce hyperemia, the FFR is normal, CFR and INR will be also normal, unless there's coexisting microvascular dysfunction. If we have both combined spasm and microvascular disease, then we will have a normal FFR but reduced coronary flow reserve and elevated index of microvascular resistance. With acetylcholine testing, we will have a significant diameter reduction with angina and ischemic ECG changes. But if the FFR is normal, the CFR is more than 2, the index of microvascular resistance is low, acetylcholine does not show diameter reduction, and there's no angina induced by acetylcholine or ischemic changes induced by acetylcholine, so this is non-cardiac chest pain. So these are the possible iterations. A normal FFR, a normal CFR, a normal IMR means no coronary microvascular dysfunction. A normal FFR with reduced CFR and elevated IMR means coronary microvascular dysfunction. With acetylcholine testing, we also diagnose vasospastic angina in the epicardial vessels or in the microvasculature, and we can of course have a mix of both, and if none of these is positive, then the chest pain is non-cardiac. And the final aspect of ANOCA is treatment. Of course, we need to tackle the causes of endothelial dysfunction, controlling blood pressure, dyslipidemia, diabetes mellitus, smoke cessation, weight management, exercise, and a healthy diet. ACE inhibitors and statins can also improve endothelial function and may be useful in these patients. Coming to anginal relief, we have around 11 medications to relieve anginal chest pain, and the choice between these medications needs to be tailored according to each patient's situation. If these medications fail, then we have other options like spinal cord stimulation, cognitive therapy, enhanced external counterpulsations, transmyocardial revascularization by laser and stem cells, and we will give a comprehensive account on the relief of anginal pain in the coming episode. And that brings us to the end of today's episode. I'm truly interested to hear about your experiences. How do you personally navigate the challenges of ANOCA? Are the necessary diagnostic tests readily available in your area? Please share your insights and experiences in the comments below. Your stories can be so helpful to others.
Thank you so much for tuning in today. If you found this episode helpful or informative, please give it a thumbs up and consider subscribing to the channel for more content like this. Don't forget to hit that notification bell so you never miss a new episode. Until next time, take care.